Welcome back to another edition of the Hart2Heart Podcast. And my guest today is Dr. Tro. So, Dr. Tro, welcome to the show, brother.
Happy to be here. I'm surprised they're letting us get together, but here we are. Happy to be here. Two doctors. Hopefully we have a good conversation.
Yeah, brother. Well, I've been following you on Twitter for a while. I had one of your colleagues on my podcast recently, or your podcast host, I believe, in Dr. Brian Lenskes. And I've been, seeing what you've been doing with your low-carb MD podcast. You've had quite a bit of success with that. So how did you, come to this full circle journey? Because it seems like at one point you were a guy who was, way overweight, and then now you're obviously a guy who's not overweight. So how did you how did you land on low carb? Like, how did you discover that this is the solution that's going to get me lean?
Trial and error. Well, look, I don't know how much you want to go into this, but, go back to my childhood. What made me want to be a doctor was when I was 13 years old, I was sitting in my pediatrician's office for my 13th annual checkup. And I was the current weight I am now, which is 205 pounds. But I was 13 and obviously much shorter than I am now. And he said to me, a lot of obesity struggles in my family, and he took care of our whole family. After making me wait in his office for about an hour and a half watching TV, he looked at me and said, you should really be embarrassed. You're going to be no different than your family. This is what he said to me. He said, you're fat, flat out. And I remember the first thing I thought walking out of that meeting, and I remember it so vividly in the office it was this motherfucker just told me, after making me wait for an hour and a half watching TV, I could have been on a fucking treadmill. And I remember thinking this, like, why didn't you have a fucking bike in your waiting room? And I remember being 13 and angry, just angry. I'm like, my family goes to you. What have you done for them? Now you're coming and turning on me. Like, you're the doctor, right? This is what I thought. And
So he was kind of putting the blame on 100%, you.
100%. He put the blame on me. And I remember at that point, I'm going to be a fucking doctor. And it was anger. There was a lot of anger, man. A lot of rage, a lot of rage. And I was a chunky little kid, of course I faced.
Anger is an interesting, fuel.
Yeah. I mean, that was my primordial ooze. I mean, fast forward, you go, so I faced a lot of troubles, man, early on, but I know I wanted to go into medicine. I tried, calorie counting, and I had a small bit of success basically being an anorexic teenager, and then going into veganism, and I just couldn't keep it up. I couldn't keep the weight off. And that just the weight kept going on and on and on. I found myself in college, 50 pounds heavier, med school, 50 pounds heavier, residency, in internal medicine, 50 pounds heavier. And, I'm a board certified doctor in internal medicine, and I'm 350 pounds. This is 10 years ago, right? And 10 years ago, Mike, that's when my wife was like, she's funny. She was like, my wife's an attorney, and she looks at me, she says, Tro, she said, she's playing me. She's like, how did you do on your board exam? I was like, yeah, I scored in the 90th percentile on my board exam. She goes, so you're a smart doctor? And I'm like, yeah, I'm a smart doctor, and she's like, so how does obesity work? And then she turned it emotional. She's like, the way hepatitis, the way you knew that, the way whatever, my thoracic aortic aneurysms, the way you knew these things, can you understand obesity in that much more depth? And I'm like, why are you bringing this up? Because I know she's got an ulterior motive. She's like, well, are you going to be around? She was pregnant, with our son, our youngest son. And so it was right around that time, maybe a little bit before that. She said, are you going to be alive? Right? And that's my journey right then and there was like, okay, let me go be the world's expert on obesity. Let me learn everything there is to learn about obesity. And that's like where my most recent sort
This
of...
was about 10 years ago?
Yeah, right around 10 years ago. Correct, yeah. So then what do you do, right? So like, you're a doctor, right? If you were looking at the treatment for pneumonia, what would you do?
Give them an antibiotic.
Yeah, no, but how would you figure out which antibiotic works the best? Which antibiotic do you give them?
I mean, you have to research it. Obviously, you're going to have to look at, what type of pneumonia that particular person has. I mean, you don't know if it's, it can be treated inpatient, outpatient, if potentially they need steroids on top of that, potentially they don't. Like, there's a bunch of other factors, obviously, that can go into it. But when you say pneumonia, the first thing that comes to mind is antibiotics.
Yeah, right. So you're like, okay, is this bacterial? Is it viral? Is it fungal? Does this guy have HIV and doing IV drugs? Like, your mind is like going all these different places, like to just try to figure out. And then once you figure out the etiology, your brain is like, as a doctor, is like, what is the best treatment? What is the least side effects? Right? And so you go to the data, right, to try to see all the head-to-head studies. What works better? What is the least side effects? How does it work? How does the antibiotic work? What does it do? What is it, right? So that's where I started, brother. I started like it was pneumonia, and I was going to be the world's expert on pneumonia. So I read anything you can imagine. I don't think I've met like maybe 5 people who've read more than I have, and I'm not here to like, it's not to be conceited. It's just that's how much rage, inspiration, arrogance I had at the time. I was just going to be the world's best. I'm going to figure this out. And so you go and you read. Like I read 300, books from doctors, right? I read 3 textbooks on obesity. I read 3,000 original articles, read the supplements, I just kept reading. And then you look at the data, and then you start to see the fucking house of cards, right? You see the house of cards that is nutritional science. How we got to say, count your calories. How we got to say, eat more grains. How we got to say, eat lean meat, right? How exactly did we get there? You start to see it's all a crock of shit, right? And then you look at the interventional data, like tell one group, count your calories, tell another group, just eat less fat. I'm even going to say less fat. Forget about low carb. I'm the low carb doctor. Just count your calories is worse advice than just eat less fat. And eat less fat is worse advice than almost any other diet, right? So it's all in the literature and the head-to-head data. It's like you looked at it's sort of like you looked for an antibiotic and the whole world is using Z-Paks, and Z-Paks have like 60% resistance rates now. Like nobody should be using Z-Paks, right? But that's what it was like. You start to understand when you look into the totality of the data, how fucked up it all is. And if you've been exposed to the COVID nonsense, you know how they could take science, manipulate it to just present the message they want, right? And not to say that they're
so with regards to
bad
the
people.
research that you found, like what was it that you found that was definitely wrong that was being said in the mainstream media about nutrition? Like, was it you feel that
100%.
calories don't matter? Like what were like the main things that you felt were being said in the media?
Well, so like, okay, so let's start at this concept of energy balance, right? The concept of energy balance is a blame so you have to understand my bias. My bias is fuck doctors, okay? Fuck the system, and they have fucked up. Look at this epidemic. We have 50% of people in the United States who are obese, right? So they have watched as this happened, right? They have watched as obesity went from 10% to 50%. So you have to understand my bias is they fucked up. They're not taking ownership, right? This is what brought me into medicine. They are not taking ownership over the fact that diabetes has tripled in the past several decades, right? Since my doctor who shamed me at the age of 13 to now, we've failed. So when you go back and you look at, okay, what interventions for obesity are more effective? And, we have direct head-to-head trials with, count your calories and let's see what happens. Okay. And we have other trials that say, well, just go low fat, right? They compared calorie counting to low fat, right? They told half of the group to do calorie counting, half the group to do low fat. Counting calories does worse, right? They do worse. So right off the bat, as an intervention, as a doctor, as a trainer.
On this?
Yeah, absolutely. I've lectured on this. Yeah, I share the data, right? So count your calories as a approach to obesity is inferior to low fat. Then you go into data for like the different diets. Let's just say you take low fat versus low carb. Out of the, let's just say, 100 interventional trials, 98 favor low carb. Okay, and the two that don't favor low carb, still low carb lost more weight. It was like not statistically significant. It was on the border of statistical significance. So, basically 95% of the trials, low carb is superior. So as a person who struggled with obesity his whole life, his family struggled, I don't give a shit what diet I do. I was doing veganism as a 15-year-old kid with an eating disorder. I would have done anything as somebody who's like struggled with weight. But I went to low carb because the data supported it. And this idea of count your calories as an approach to changing behavior, it has no basis in the literature. Zero, none. Right? So meaning like, okay, let's just say you look at in New York City.
But wouldn't you think that eating excess calories is going to put on weight?
So that's a whole different discussion. So now we're talking about there's two different discussions here is thermodynamics and like understanding how the body metabolizes and the problem, there's problems with that. What I'm talking about is right now, but we can get into that. If you look at calories as an approach, right, as a public health doctor to patient approach to dieting, it is completely ineffective. And it's ineffective on, as an intervention for a doctor or a dietitian to tell somebody compared to other modalities. It's sort of like a last line antibiotic. Like if you've tried low fat, you've tried low carb. Yeah.
We can talk a little bit more about, about excess calories potentially, causing weight gain. But what you're basically just saying is you're not necessarily saying that that's incorrect. What you're saying right now is just that calorie counting as a whole for public health doesn't lead to weight loss.
Yeah, not only not on public health, on an interventional basis, which is how doctors, dietitians, personal trainers should be counseling people with obesity, right? It does not, it's ineffective. It should be last line. In fact, if you look at the data, low carb is superior. Next best is probably high protein, right? High protein. Next best is probably like a low fat or a Mediterranean approach, which is about the same efficacy. Then next best is cut your calories, right? So it should be fourth line. Right? I'm not to say it's ineffective. They do better than, the standard, somebody who doesn't give a shit at all, but it's no more effective. It's probably slightly less effective than just count the amount of hours you eat and keep it under 6 hours. So if it's me and I'm trying to tell somebody really quick and effective, like I have 1 minute to say, do this, it's going to be count your hours. Right? It's easier than counting your calories. It won't sap your energy, and you're just as likely to lose the same amount of weight. Right? So as an approach.
Yeah, I think that's the main reason why a lot of people like the intermittent fasting approach is because it's so easy. Like essentially all you're just saying is, okay, you can't eat, during this period of the day, these 16 hours, 18 hours, however many hours you choose, you can't eat during these hours. So it's very easy for people to implement that strategy. Counting calories, on the other hand, can be pretty tedious. Some people may be able to do it correctly, and I'm sure some people have done it, correctly. But for the most part, it can be very tedious overall to be counting calories all day.
So we have data on that. If you look at people who are overweight or obese, they will be off on their calculations by about 50% because of subconscious eating, because of underestimation, whatever. There's a lot of reasons why that happens. The only people that can do it well are bodybuilders and anorexic dietitians. That's it, right? The people who don't even struggle with weight. So the people recommending to do this are like the fit personal trainer and the anorexic dietitian, they're the only ones who do it well, right? So it's an ineffective message for anybody struggling with weight as an intervention to put upon somebody, right? So first and foremost, ineffective. When they've done studies where they actually give calorie information to people in fast food joints, it does not lead to any changes in how they purchase, right? They've done studies in college kids where they tell them the calories and the price of the food. If you tell a young male the amount of calories, they will actually eat more. They will actually eat more. The only people who eat less with calorie information are abstained eaters, which are typically like thin, women in the historic literature, right? So as an intervention, calorie counting is just bullshit. It's just BS. I mean, we can get into the thermodynamics side, which is a whole nother side of it, right? So but if you're a doctor, a dietitian, a nutritionist, a personal trainer, it's the last line. It should be last line in terms of how effective it is.
All right, so we just chatted about, a little bit of calories in, calories out strategy and how that doesn't work, but what about the thermodynamics part? So if someone is eating excessive calories, are they going to put weight on?
It's a tough question. So you're stating the answer and then you're working backwards. So let's reformulate this, right? So let's reformulate it. So first of all, if you have somebody with obesity, right, they are going to subconsciously eat. So me, I was 350 pounds, right? When I walk in the kitchen, I am picking at some almonds. It doesn't process, right? Okay. I don't even know that I'm doing it, right? I just do it, right? And if I'm on a phone, you ever drive somewhere, Mike, and you're talking on the phone and you don't know how you got there, right? And how scary is that we're driving cars, we don't know how we got there. Imagine somebody with obesity. That's like what they have with food. There's so much subconscious eating. They're not even processing. Like I'm on a phone call, I ate a bunch of olives that were just on my counter. I wouldn't have even known if I didn't see a bowl of a bunch of pits, right? So the thing is you have to understand when you think about calories for the person with obesity, whether it's subconscious eating, whether it's undercounting, right, underestimating the amount of calories they're eating, they're going to struggle, right? So, but now to go back to your question is, what do you do? What about the same calories? So take that person, the 350 pound tro, right? And we're going to give them two different diets and I'll tell you which one will gain weight. So one is 2,500 calories of processed food. Okay. 2,500 calories or 3,000 calories of processed food. Okay. Meaning high in carbohydrates, high in, processed oils, high in sugar, right? And low in protein. Mm-hmm. And then you're going to give the other person a diet of 3,500 or 3,000 calories. Okay, actually, you know what? I'm going to increase it. I'm going to give that person more calories and watch my diet, right? So 3,000 calories of processed food for a lifetime. Okay? And then I'm going to give, some intermittent fasting, real food. Okay? I'm going to give 60% protein and 40% fat. Let's just say like meat, fish, chicken, eggs, and Greek yogurt, right? And some green leafy vegetables, right? And that's what I'm going to do. And I'm going to give 500 less calories for a lifetime. Okay, a lifetime. Who do you think gains more weight?
Obviously, the person who is eating less calories is the person that you would think would gain the least amount of weight. But the way that you've frame the question, the person who's probably eating more calories is probably not going to gain the weight.
So let's walk through it, right? Okay, so you have calories from processed carbs and fat, which we're going to swap out for 60% energy from protein, which is a very high. I'm not recommending this, but so if you have, let's just say 1,500 calories of protein, right? Your body's going to waste because of thermic energy, meaning like inefficiently metabolizing protein and wasting heat. It's going to, out of those 1,500 calories, your body will see 1,100. Okay, your body will actually see 1,100 of those calories, right?
You're talking about like the thermal effect of food and that.
Exactly, bingo, right? So you've just dropped about 400 calories, right? Let's just say 25% or so, right? Or 20 to 25%.
But maybe we should explain, to a lot of people don't know what thermal effect of food is. So, maybe just explain that real quickly.
So when your body is digesting protein, it inefficiently metabolizes the protein and wastes it to heat, right? There's some, the meat sweats basically, right? But it wastes it to heat, meaning it's inefficiently metabolizing this, right? And so you can actually eat more calories and it affects your, energy balance 20% less than calories from processed carbs, let's say, or sugar.
So if you were to eat carbohydrates or fat, what would be the burn rate there?
I mean, there's estimates as low as 1%. There's some estimates, if it's processed food, it's like a negative effect, right? Meaning like a 10% surplus. But anywhere from like, let's just say 0 to 10% thermic energy would be wasted, right? Okay. So, but probably less, probably 5% or less if you look at the totality of the data. For protein, it's probably 20 to 25%, depending on the person, right? Maybe as low as 15, maybe as high as 30, right? Depending on some other factors. So let's just say, for the sake of easy math, we have 1,500, let's just say 20%. We're talking about, roughly 300 calories, right? So that person who was having 3,500 calories and 1,500 was protein, right? They are actually eating, 3,200 now because of the thermic effect. Now, if you add in that somebody maintains a low carbohydrate diet, David Ludwig showed that they increase their energy expenditure, right? And this has been shown in meta-analysis as well, by 200 calories, right? So they are increasing energy expenditure we don't know where that energy goes, but it goes somewhere, right? Spontaneous energy expenditure goes up 200 calories in somebody who's weight maintained for 5 months, right? So these two scenarios, somebody who's high protein, carb restricted, they actually will technically not have any difference in weight loss over a lifetime, even though somebody's eating 500 more calories a day, right? 500 calories more a day. So, and this is nothing to do with the effects on hunger even, right? So what those calories did to that person's experience, like eating processed food all day, how that makes them hungry. There's some evidence that in and of itself lowers energy expenditure, eating processed food, by maybe 5 or 10%. There's disparate data, some that say it doesn't do anything, some that says up to 10% lowering the metabolism, eating the processed food. So, but even if you take a straight thermodynamic approach, it is so complicated for the average person, it's almost worthless, right? I mean, we just gave somebody who's eating 500 calories more, probably going to lose more weight, in my opinion, over a lifetime.
Yeah, the other thing that comes into play there is hormones, right? Because if you put someone on, two guys on the same diet, but you stack one guy on a bunch of hormones and the other guy's not, like obviously their body composition is going to be completely different. So, like what's going on there, Tro?
100%. So if you look at testosterone, for example, for men, right? And actually PCOS, so if you look at a low carbohydrate diet, a diet high in saturated fat and cholesterol, reliably increases testosterone, reliably. Okay, and a calorie restricted diet reliably decreases testosterone, right? So this is in the literature. It's not controversial. Low carb, higher fat diets increase testosterone. Okay, and in women, interestingly, it reliably, regulates testosterone. So in men, they will get more testosterone. In women with PCOS, a low carb diet, and meta-analysis was just published this week, will reliably regulate the excessive testosterone they see in PCOS.
Does it for sure increase your free testosterone? Because I thought with a low carb diet, it will increase your SHBG, which would then bind your testosterone, which would decrease your free testosterone.
So high protein diets, so calorie restricted high protein diets will increase SHBG, reliably lower both total testosterone and free testosterone. So there's some, but ketogenic diets have been shown to raise testosterone. Now there's been no.
So it's the excessive fat that basically is responsible for the increase in the free testosterone. Like, what's the mechanism there?
Yeah, it's a precursor. Saturated fat and cholesterol is a precursor to testosterone. The problem with the data, because you're right, a lot of the weight loss data shows that increase in SHBG that happens, right? And this is true for calorie-restricted diets. This is true for high-protein diets, and it's true for low-carb, higher-fat diets, right? But nobody's done like a weight-maintained ketogenic diet. But if you look at all of those, testosterone is reliably increased on the low-carb, higher-fat diet, not necessarily high-fat, right? If you look at calorie-restricted, high-carb, if you look at low-carb, high-protein, and if you look at low-carb, high-fat, testosterone will be higher if you systematically analyze them on the low-carb, high-fat diet, likely because saturated fat and cholesterol are precursors to testosterone. In women, the opposite's true. In PCOS, which is a problem with ovaries having.
Come on, Tro. Everyone doesn't know what PCOS is. Polycystic ovarian syndrome.
Yeah. So yeah, I'm trying to characterize it. It's lifelong high testosterone. Women can get facial hair. They can get problems of fertility. In women who go on a low carb ketogenic diet, their testosterone levels drop and their LH and FSH improve. And a recent meta-analysis showed that. So the hormonal stuff you're talking about, and this is just sex hormones. Wait until we get into CCK, neuropeptide YY, ghrelin, right? The new wonder drug, which is GLP-1s. These are all reliably improved on a low-carb diet compared to low-fat diets. We've done year-long studies and assessed these hormones. The hormonal milieu is superior on a low-carb diet. What you won't get with the low-carb diet is like that high amount of fiber, unless you seek it out. You can get it.
What do you think of that, though? Like, would you add fiber to a low-carb diet?
For what end?
So for what end? Well, I think there's a couple different reasons. I mean, there's a meta-analysis that showed that just by adding 10 grams of fiber to your diet a day, it'll decrease your all-cause mortality by 10%. And there's a lot of people who, I know the one thing that we may disagree on, and I don't even know, I haven't really made my mind up on LDL yet, but if you are someone who is in the low LDL camp, fiber can lower your LDL and then potentially decrease the risk of cardiovascular disease. So there's a couple different reasons to add fiber, and also just for the satiety factor is linked to lower blood sugar levels. So there's a lot of really, really good evidence for fiber. So why would you not add that back in if you're on a low carb diet and you don't get too much fiber in your diet?
Yeah, I would tell you, this is a long discussion. We can go through it all. I don't know how much time you have, but I got time. So if you look at fiber, okay, so let's go through it, right? So the data from fiber came from a caloric excessive state, right? So the data from fiber that's positive comes mainly from the population-based data, which is the same data that Fauci would use to say that masks are effective, right? That has since been debunked by the Cochrane's group, right? I don't know if this will make it through the Canadian censorship or not, but I
hope so. I think it will.
Yeah. So meaning that the fibers benefit on from the perspective of nutrition is largely been based on observational data, meaning like people who report eating more fiber, right, tend to be healthier people, right? So there's that, right? Then but again, you have to understand this is in the context of a high processed carb, high trans fat, high processed oil diet, where fiber would slow and maybe potentially lower the digestion of those things, right? So if you're not eating any of that shit, does fiber actually help you? I don't know, right? I have no idea. And if you look at interventionally, the data for, let's just say, you mentioned LDL, we can get into that, but if you look at obesity, increasing satiety, if you look at the meta-analysis for fiber and satiety, it's all bullshit. right? So like the studies that power the fiber being beneficial come from like Yacon syrup, which literally made women like vomit at high doses, that they had to go back, lower the dose, and like exclude arms of people.
What about with
vomiting.
Psyllium Husk specifically?
Yeah, look, I recommend Psyllium Husk to some patients in my, for various issues.
So what would you recommend Psyllium Husk for? And that's what I really mean when I'm talking about fiber. That's one that seems to have the most data.
Yeah. So again, it depends on the intervention. Very few people. So let's just say you had somebody with a very high cholesterol, and let's say they wanted to lower the cholesterol. You could, and they were cholesterol absorbers. You do a cholesterol balance test. You look at their genetics. You could sort of see if they have the genes for cholesterol absorption, or if they have, if they absorb plant sterols, right? You look for that, and if they have these things, or you just do it blindly as an intervention, take it for a month, see if it mitigates your level. I'll tell you, I do not think that modern lipidology understands the low carbohydrate state when it comes to lipids. This is why I've published on it several times. And, there's data still coming out on that. So if you look at like the data, there's about a 10% effect of reduction in LDL, 10 to 15% reduction in LDL from adding fiber. We published a case series from my clinic along with a analysis from a large survey. We were able to do a 50% reduction in cholesterol on people with a low carbohydrate. We're doing a low carbohydrate diet by adding back non-fiber glycemic carbs to about 50 grams. So just let this sink in for a little bit.
So what carbs were those?
They were starches. They were like sweet potatoes and there's reasons why that worked in the people that we used it in.
Wouldn't there be a little bit of fiber though in the sweet potato?
Yeah, but it's so another one we for other people we recommended rice, which has another person had more starchy vegetables. But it's there's been experiments. There's been like people who've done it with white bread, who've demonstrated the same findings. Which is when you're in so if you look at the data for LDL increases on a low carb diet, or fasting, right? If you look at Ramadan fasting increases LDL, particularly in low BMI people. So if you don't have fat on your body and you're asking your body not to use carbohydrate for fuel, your body is going to upregulate cholesterol to more efficiently mobilize fat as a fuel source. Right. So this has reliably been shown in the data for anorexia, in the data for fasting, right? The lower the BMI goes, and if they're in a fasted or, carb restricted state, the higher the cholesterol will go. So, we have people who are saying, well, add fiber. I've seen people with an LDL, I don't know if you guys use millimolars, of 700, right? So an LDL of 700, what's that in millimolars? I don't know, Mike,
Yeah, we used a little bit different scales here than you guys do for sure.
Let's do the conversion. I don't know if your listeners are so that's, I think it's like 15. It's probably like does 15 sound really high?
15 sounds insanely high.
Yeah, 18. Yes, exactly. So
if something's like above like 5 here in Canada, it's
all right, perfect. Great. So we took a patient who came to me with a 18 LDL.
I've never seen someone with an LDL of 18.
Yeah. We see these people all the time. And so we gave him back carbohydrates, 50 grams of carbohydrates, right? And his LDL went down to 150, which would be 3.8, Canadian.
Yeah, that's pretty reasonable.
Right. So, and we didn't do it. And so I've taken these people who have astronomical increases in their LDL, and I'm like, they're like, maybe there's somebody who has a neurologic issue that they can't go off a ketogenic diet, and they don't want to take a medication. They've said like, I will not take a medication. I'll give them fiber as an attempt to try to lower it. Very rarely is there a large decrease. It comes by adding back carbohydrates predominantly. In fact, if you look at it, if I had to estimate the data that I've seen it's pending publication, About 2/3 of the effect of the LDL increase on a low carb diet comes from carb restriction, and about the other third comes from the saturated fat intake, the increase in saturated fat. So the maximum effect on a sort of overall level you'll get with adding back psyllium husk will be a 1/3 reduction versus 2/3 of the lowering could be done by reintroducing carbohydrates. So this is the low carb guy saying add back carbs if your LDL shot up. Like this isn't a dogma. This is like, I'm giving you the most cutting edge data out there. And lipidologists have literally called me like a disgrace for telling people to do this. And so much so that I had to publish this so they could see what it is we're doing.
So if someone has a high LDL, then your approach is to add in non-fibrous carbohydrates back to their diet.
So they can add all the fiber they want. Okay. But if that leads to a decrease in energy, if they're eating less now, right? Because these people want to remain low carb, right? So you have to understand, like, they're like, I'm going to eat low carb. I will not change, right? So now my task, and a lot of people coming to me, they don't want medications. They're like, I know this is diet induced. When I was vegan, my LDL was, 3.5, right? So they've pigeoned me into a hole, and the only way I can help them is through understanding nutrition better. We have given people high dose psyllium husk. It does not generally lower it. It is adding back glycemic carbohydrates, right?
Okay.
It is adding back starch. Now, that's not to say this is a very select population, and these people are in a controlled setting. We're getting calcium scores. We're ultrasounding their carotids, looking for plaque, where they have signed a paper saying they don't want medication, and there's nothing I could say that will change that, right? I mean, So like, the listeners got to be very cautious here. These are like incredibly monitored people.
Let's talk too just about lipids and lipid panels, because I'm very curious as to what you look for on a lipid panel. Like, are you looking for low triglycerides? Like, do you look at the triglyceride to HDL ratio? Do you look at the LDL to HDL ratio? Like, what's your approach when you're looking at lipids, and what do you like to see on a lipid panel?
Yeah, I mean, look, it matters how cheap you want to do this. So if you're looking at a lipid panel, typically contains total cholesterol, LDL, HDL, and it may have a VLDL on it, and it contains triglycerides. And it says two different things, if you ask me. It says two different clear things. One is, are you insulin resistant, right? If your triglycerides are high and your HDL is low and your VLDL is high, you are insulin resistant. That's one thing.
What ratio would you strive for your patients to have there for triglycerides to HDL?
The lowest possible triglyceride, the highest possible HDL within reason, and the lowest possible VLDL.
But you try to get it to be like 2-to-1, or...
So 1-to-1 would be awesome. Triglycerides equaling HDL, that would be freaking great.
And if triglycerides were, half of HDL, that would be even better.
Yeah, if possible. Yeah. Well, it depends. Do they have anorexia, or are they malnourished? Maybe that's not the case, right?
Okay.
So I think for the obesity epidemic and insulin resistance epidemic, we want a low triglyceride, high HDL. That's one thing the lipid panel communicates.
What do you look for in the LDL? Like, what's your ideal LDL number?
So the LDL, it's predominantly three things, right? So 10% is fiber intake, right? 10% is saturated fat intake, right? And then 80% is genetics, right? 80% is genetics, predominantly in like somebody who's eating a mixed diet, right? When you become carb restricted, you are tasking your body to make more cholesterol. When you are fasting, you are tasking your body to make more cholesterol, okay? And the leaner you get, meaning the less bioavailable fat you have, okay, you are going to ask your body to make more and more cholesterol.
So just go back to that for a sec, because that's interesting, because you mentioned about anorexics, and I wanted to interrupt about that earlier. So you're saying that anorexics then have very high cholesterol because their body mass is so low.
Yes, if they are like in a current state of anorexia and not eating, and they're very low body fat, it is reliably shown to increase their cholesterol. And if you go to the psychiatry data, right, this is what they say. The phenomenon disappears upon refeeding. So they're eating more saturated fat when they're refeeding. They're also eating more carbohydrates. So did the saturated fat lower their cholesterol? Because the solution to these metabolic disasters is refeeding. They're adding saturated fat. They're also adding calories. They're also adding carbohydrates, right? So you understand, like, there is a lot of, let's go back to our first discussion. We just said if you have pneumonia, right? And the first thing you said, what is the etiology? Right? So when you have cholesterol, it's the same thing. What is the etiology? Right? And 10% of the time, maybe it's a lack of fiber. 10% of the time, it's the saturated fat, right? 80% of the time, it's genetics. And then there are special considerations when it comes to the low-carb fasted state, okay? And we see that in anorexia. We see that in low-carb diets, very strict low-carb diets. And we see that in low-carb athletes. And we see it in, Ramadan fasting. I mean, it's all there.
But do you try to get people's LDL low overall, or do you have a specific number? Like, what's your goal with your patients there?
It depends, right? So I had a patient yesterday who has MS, has a history of neuropathy. Well, did you know that there's data suggesting that diabetic neuropathy improves with a higher LDL? There's data suggesting people on a ketogenic diet have improved outcomes with MS, right? Not huge amounts of data. These are small studies, right? But there's pretty big studies with functional MRI data on nerves. It was published in JAMA 2 years ago. Higher LDL, better diabetic neuropathy outcomes, right? So it depends on the patient. If, and it depends on what their goals are.
You don't agree with Dr. Attia's approach of just, get your LDL and ApoB as low as humanly possible, essentially.
Okay, well, let's just go back. So now I've described a quality of life issue that's improved or potentially improved with a higher cholesterol, right? So what about hypotestosteronism, right? They have a poor quality of life, these men, right? And, and you're not going to give them a little bit of fat, saturated fat, and accept a modest increase in LDL.
Yeah.
Right? So let's just take the other side, which is Attia's side. He was age 40 when he had, or 30 something when he had coronary calcium, right? So his bias is 30 something, he's got heart disease. So yeah, I think that if your primary focus is heart disease and you're at a high risk of heart disease, right? Like you may want to really start considering, is there modifiable things you can control LDL with? Right?
I agree. And it's kind of like the aspirin thing. Like if, there's no ulcers in your family, you have no history of ulcers, but there's a major, history of stroke. You've had a stroke before, probably taking an aspirin a day might be beneficial for you, but just for the general purpose.
There's data to support that. So we have modeling data with huge data sets showing that if your CAC, if your coronary artery calcium score, which is a CAT scan on the heart, if that's over 100, you're going to likely benefit with aspirin use, right? Now, but generally, willy-nilly, if you give it to everybody, they're going to have more bleeding than harm, more bleeding and more harm than good. So if you're Peter Attia, who I think is, he's done a great job grifting, in my opinion. He single-handedly set back low-carb research 20 years. Okay, with Nusi, he single-handedly, did that. Okay, he, and I don't want to get into that, but I agree with a lot of his concepts, which is start to, think about medicine more proactively, think about screening and risk stratifying more accurately, think about precision medicine. I love all that stuff, but I don't like any of the rest of it.
Yeah, I understand. There's a lot of people who are upset about the kind of statin thing, but I do want to talk to you a little bit about that. Like, is there an alarming number? Like, say if someone is, pretty low risk overall for cardiovascular disease, but, I know I'm pretty hard on the numbers here, but I think a lot of people want to know this. But say, they get up to 5 or 6 millimoles, 7 millimoles. Like, is there a number where you're like, okay, you know what, like this is getting way too high here. I think you should probably start a statin or at least do something to get your LDL, lower here. Is there like an alarm number that you have?
Look, man, I don't have an alarm because I have seen the what number was it? 13?
18, I think you
yeah,
said.
18. Yeah, I've seen 13, and I published on this, right? So
Yeah.
we literally took our case report, we published it so everybody else could go see what we're doing and learn from it. And just so you understand the reduction that we were able to achieve, so that patient that I'm talking about and several patients like him had a drop of over 10 millimolars. This is more potent than the injection drug Peter Attia, promotes, right? Usage of off label, by the way, right? So just so you know, like, my point is not to say what concerns me. Any deviation from any major deviation from the mean concerns me, and I'm curious. Why is this happening? What is it? Is it a genetic issue? Is it an absorption issue? Are you just producing cholesterol? Is it your diet? I've done countless sort of trials of psyllium husk to see with meals to see if that improves it. We've done countless trials of.
Has psyllium husk improved blood sugar controls at all?
Not really. Well, I have a carb restricted population.
Yeah.
Right. So.
What's your target for hemoglobin A1C?
Yeah. So you're getting me on the numbers. Okay. So let's go back. I'll give you LDL. Okay. I'll give you LDL. So if you look at all-cause mortality, the lowest all-cause mortality for LDL is between 120 to 140. If you look at the lowest all-cause mortality with somebody with heart disease, it's 100. An LDL of 100. So that's, let me just plug this in, man. So if you have heart disease, that's like 2.5, the lowest all-cause mortality. And if you don't have heart disease, the LDL associated with the lowest all-cause mortality is between 3.2 to 3.75.
Yeah, okay, that's what I saw recently. I actually tweeted out, it might even be some of the data that you're looking at that said that the people with the lowest all-cause mortality had an LDL of roughly about 3.5, which is kind of interesting. Yeah.
So, I mean, if you look at cardiovascular, so if I knew I was going to die of a heart attack, I would want my LDL to tend to be lower. If I had quality of life issues, appetite issues, neurologic issues, I may want it to be a little higher.
Makes sense.
Right? So, I think it's like so back to Peter Attia's thing, his bias comes from the fact that he was 36 and had coronary calcium.
Yep.
Right? So, I mean, I understand why he's saying what he's saying, but on the flip side, we have published data showing that you can lower cholesterol by over 12 points or whatever, 12 millimolars, 500. So it's not I think the problem is doctors suck. We don't know this shit. We never taught this shit. Right?
Well, we certainly don't discuss cholesterol, I think, enough. And, people have so many different opinions on this. And obviously that's going to lead to a lot of confusion with public and the patients. And, that's part of the reason I think we're in this mess with obesity to begin with. But I do want to be a little bit of a stickler too on what's your opinion on statins? Do you ever prescribe statins?
Yes, I have prescribed statins, and I'll tell you when. Okay? If a patient wants it. Okay? If a patient wants it is one. Okay? If the risk of cardiovascular disease, is high. If there's evidence of soft plaque, and if there's a high percentile of any plaque, right? Then I'll say we should talk about this discussion, right? And it's not PCSK9 inhibitors. That's not the discussion.
And that's the one that Peter Attia takes, by the way, is the PCSK9 inhibitors. But in general, which are newer, but most people take statins.
So the reason why, in my mind, so if you look at all-cause mortality data in an interventional trial, statins have been the only class to show that out of all the lipid-lowering drugs, full stop. Meaning that if you are at risk of cardiovascular disease or have cardiovascular disease, statins lower mortality, meaning you're less likely to die on the drug. Which is a huge, that's a huge thing to hand out. So even though they have the worst side effect profile, in my opinion, you get the vitamin K2 depletion, the nitric oxide issues, the CoQ10. So you get a whole bunch of shit that you got, and the increase in insulin resistance, the increase in A1C, more likely to develop diabetes, the myopathies, whatever. we also understand those side effects really well, and we can mitigate them. So if somebody needs or wants a medication, you're like, I'm going to use the best class with the best all-cause mortality data. If you then go to which drugs lowered mortality, but not statistically significant, right? Because all of the next classes of drugs have been shown to lower cardiovascular mortality, but the listener has to understand, I can lower your mortality from foot cancer by cutting off your leg reliably. I can do 100% effectiveness by cutting off your leg. You will never get leg cancer. That doesn't improve your overall quality of life or your overall mortality, because you'll likely not live as long as somebody who does not get their leg cut off. So when you're looking at cardiovascular mortality, you have to take a grain of salt and say, it depends on your risk. The higher the risk, the more likely you accept the surrogate endpoint. All right. The lower your risk, the lower likely you are to accept the surrogate endpoint. But if you look at all of the next drugs, which include PCSK9 inhibitors, bempedoic acid, Zetia or Zetamide, and colchicine for, the management of coronary disease, none of those have been shown to decrease all-cause mortality.
Was there something with colchicine recently?
Yeah, but it didn't show a reduction in all-cause mortality. It was a composite endpoint, right? So of revascularization. In fact, more people died in the colchicine.
Yeah, what did that study show? Just curious, because I didn't really look into that too much.
Yeah, so I've looked into them all. So if you look at the data, so colchicine is an anti-inflammatory drug that's been used for 30 years. The great benefit of that, for gout. So we know it works on the inflammation sort of pathway, so proving that coronary disease is also related to inflammation, right? I think very clearly now, not just cholesterol, not just insulin resistance. So colchicine is a drug that lowers uric acid and has other anti-inflammatory effects. So it showed that it reduced, it didn't even reduce cardiovascular deaths, by the way. It just reduced revascularization, MI, heart attack, right? So meaning like it just caused less heart attacks. It didn't even decrease cardiovascular death, and it did not decrease all-cause mortality. In fact, more people died on colchicine than placebo. It wasn't statistically significant, but more people died. Okay? So, that the listener has to understand it could be chance that happened, that more people died on colchicine. I don't know. You don't know. Nobody knows. And we'll never know, likely. Okay? But we just have to accept that these are the limitations of the data. So it showed that it reduced, this composite endpoint, which is, if you don't want another heart attack, that's a great drug. It's been out for a long time. We know the side effects. But will it make you live longer? I don't fucking know. Neither do you, neither do they. But everybody's writing for it.
Do you think there's anything that makes you live longer? Do you think there's any data on
statins? Statins reliably have been, in my opinion, there's good enough evidence to say there's some early data showing that bempedoic acid may, but it was a retrospective review.
And for people who don't know, bempedoic acid is basically a statin, but it just doesn't work all over the body. It's essentially just working in the liver. And so it is likely to produce less side effects overall, but we don't really have enough data on bempedoic acid versus statins right now. And it's also, I think, incredibly expensive and difficult to source, at least in Canada anyway.
Yeah, I think there's some, if you look at they did a study in primary and secondary prevention, which means you're preventing a heart attack or preventing a second heart attack, right? And the people who were doing the secondary prevention study, actually, the effects were almost minimal, probably because they were medicated in some other way. I don't really know. But the primary prevention data, when I looked at it, which was a pre-specified endpoint but retrospective review, right? It was published in JAMA. It actually had a lower all-cause mortality. And if you look at that group, it was diabetic, very low likelihood of taking a statin or Zetia, right? And so I think there's something to LDL lowering in high-risk people, right? That's my sense of but statins have the most reliable data. When you're choosing the statin, you want one that doesn't go to the brain. And so that would be rosuvastatin or pravastatin, right? So that would be my choice in terms of and I would not choose any other one. But so if you go to the other drugs, like PCSK9 inhibitors, we have now 7-year data, retrospective review suggests there may be an all-cause mortality reduction, but the prospective studies have not shown that. And it doesn't even reduce cardiovascular deaths. And the re-adjudication that was done, which is like other scientists going over what the trialists did, shows that it's even worse than they first thought. So it profoundly lowers LDL. Yes, it profoundly lowers your heart attacks, but it doesn't make you die less of heart attacks or die less. So I wouldn't use that if I'm not on a statin, personally.
What about metformin? Do you think that has any longevity benefits?
Yeah, well, let's finish up. So Zetia, which is another ezetimibe in that class of, that also, it's lowered cardiovascular deaths, right, which is a big hurdle to cross, and it has less mortality on the treatment arm, which is great. At least I could say, well, the trial had less people dying. It wasn't statistically significant. So if my choice is, if I'm faced with a choice for me or for patients that I care about, and I care about all my patients, but, statins have the highest quality data, then Zetia, and then these other ones are sort of last line, in my opinion, maybe bempedoic acid, But now to go to metformin, it's funny that all of the longevity people are backing this. Here's the problem with metformin. We didn't even know how it works. I wouldn't be so. I just found out. So maybe you know how metformin works?
Well, I mean, we know that it lowers hemoglobin A1C, but in terms of lowering expanding your lifespan, I mean, I thought that the effect would be through, having a lower hemoglobin A1C, throughout your whole life, then you would eventually live a little bit longer overall. But if that's not correct, then correct me.
Yeah. But I mean, so when we were in medical school, when did you graduate?
I graduated in 2000 from medical school, 2010.
2010. So you're a little bit later than I was. So we were educated at the same time, probably the same, like when you look at the mechanism for metformin, right? It's like unknown. That's what it says, unknown.
Well, it decreases gluconeogenesis.
Actually, how does it do that?
How does it decrease the gluconeogenesis?
So you know what?
People know that's the formation of new glucose, gluconeogenesis. So glucose is sugar, then neo is new, and then genesis, so new sugar. But go ahead.
Yeah. So this is the thing, right? The doctors are just like blind, man, and this is me too. So up until I found this out. So I'm not like, but we're just doing a lot of what we're told. Metformin makes you shit out glucose. It makes you shit out glucose. They gave it to people, they labeled glucose, and they saw where it went. And it got excreted out of basically the terminal and ileum and in the ileum, right? The last part of the small intestines.
And this is something you just discovered recently?
It was just discovered 2 years ago, bro. We didn't know, but some crazy team was like, let's do this shit and see what happens. And so, I mean, it makes sense, right? How it would cause B12 deficiency over the long term if you're disrupting the intestinal barrier in the terminal ileum, right? This is how metformin causes B12 deficiency over the long term. And the other reason why I don't like it for longevity, by the way, is it impairs the AMP. It impairs the benefits of exercise, the potential for benefit from exercise. So I'm not a fan of metformin unless somebody has high sugar and they're already low in carbohydrate.
And same with berberine as well. Like you wouldn't just, throw someone.
Berberine's slightly better in terms of, in my opinion, if you look at the side effect profile, slightly better. And it doesn't have as the potential for as negative consequences in the setting of exercise. So all my patients, I'm striving to get them to exercise, resistance training, cardiovascular exercise regularly, right? So on those people, I don't want metformin. I don't even want berberine, but but if somebody had an A1C of 6 and they're doing everything, I would consider metformin. You got to use B12 over the long term with metformin in the long term. But, this longevity stuff is kind of a grift. And sorry if I don't.
I know I'm a little bit with you on that as well. Like, I think that, people are getting into it a little bit too much and getting sort of like obsessed with it. And, there's certainly a lot of things that we can do. And I did enjoy, Peter Attia's book and like the health span and lifespan. Like I get that, but I think we do need to focus on,
You see the triggering?
I
You see the
see it.
triggering? Yeah, you see the
I see but we do need to focus on like quality of life, I think, and that's something that we, haven't done, I think, in medicine as well recently. But I know we only have a few minutes left there, Tro. So, can you tell everyone, is there anything else actually that we haven't discussed today that you wanted to discuss?
No, man, we got to get you on our podcast. No, I mean, the last thing I'd say is, go back to that doctor that I talked about when I was 13. He was like, it's your family is fat. You're going to be fat just like the rest of them. He gave me no tools, right? He gave me no tools, no insight. No tools, no insight, right? And in fact, probably gave me some, I mean, look at it. I'm talking about him now, Dr. Adis, how many ever years later, right? So he left some emotional imprint on me,
It's like Michael Jordan's retirement speech, still talking about his high school coach.
Yeah, exactly, right? So the thing is I've devoted my life, over the last 10 years to helping people with obesity conquer obesity, right? To not be a victim of the sort of the medical system, the healthcare system, not be at the whim of them, to empower patients. We use, I don't know if you're in a private clinic or what, but, we have a clinic, we have remote scales, remote blood pressure cuffs, CGMs, we have an app, we have communities, we have daily meetings people could go into, we have health coaches, personal trainers. We have regular labs. We have education videos they can watch on their own time, asynchronous care. You don't have to tell me your blood pressure. I'm monitoring it. You don't have to tell me your weight. We're tracking it. We even know when you're not using these things, when you're not getting on the scale, not using the app. So we know to say, hey, what's going on? I've devoted my life, right, to not being that guy, right? I've devoted my life, and we work with big employers, right? Big employers come to us and say, help us get our people less sick. And we focus on diabetes and obesity remission. We've worked with several big employers. We've been covered by CBS, PBS, Yahoo Finance, USA Today. Our program has been, covered by all these. We've published on our program because it produces results very similar to these blockbuster medications in terms of the effects of weight loss and weight loss maintenance. So, what I'd say is, if you have doctors who listen in, I'm sure you have a big following of healthcare providers who probably look up to you and are hearing this. You can be great. You can be an amazing practice, right? Take everything that's wrong with medicine and you can change it, right? That would be the last thing I'd say. You do not have to accept, the nonsense. Just like one thing, 1 minute. I know you're like, let's get the hell out of here. This guy talks so much.
This is awesome. This is awesome. Yeah. Keep going.
I was on the phone because I had a patient who I needed to get a CAT scan for of the chest, pulmonary nodules. We're looking for pulmonary nodules, and he had a long-standing smoking history, right? And I got the CAT scan approved 2 months ago, and they gave him a month to get the scan, but he wasn't able to do it, social reasons. So I had to get another approval. And I had to do what's called a peer-to-peer, which is, in the U.S. system, the insurance company says, well, we just got to make sure you got to get on the phone with another doctor to make sure you ordering that is a legitimate order, even though the guidelines support its use. So, which I found insane because I just got it approved. He just wasn't able to get to it. And why am I getting a whole nother approval? So I get on the phone with this doctor and I'm explaining to him the case history, 15-year packs, smoking history and do whatever. And quit, 10 years ago. And he wasn't able to get it. You guys just approved it. And I was like, how sad is it that there's 2 doctors here? We're wasting our time going over this case when you should just automatically approve this, right? And I said to him, do you have somebody you can go to suggest a change? Suggest like this is a waste of 2 doctors' time. We could be going helping the world. We could be saving people right now, right? And I was like, is there somebody you could tell? Just so I'm going through it right now. I don't mind. We're on the phone. I said, can you go tell your supervisor? And he's like, yeah, I can't do that. I'm like, who is your supervisor? He's like, I don't talk to him too much. I was like, well, can you talk to him and talk about systemic change like this? Like, this doesn't make sense. Just because it's past the expiry for a test, like we shouldn't have to waste 2 doctors' times. Can you go and tell me, and, go to him and suggest this change? He's like, dude, why don't we just make this easy? I'll give you the approval. They'll do it. I was like, you're not understanding me. We have to make medicine better. Can you go to the person? And if you don't want to go to him, give me the name of that person. I will talk to them and tell them we have to do this change, because we could make this better for millions of fucking doctors out there, not needing to waste 15 minutes on a bullshit call. And he's like, I'm not going to give you my boss's name. I was like, so you're telling me you're fine with, you'd prefer to just give me the approval. You're a doctor. You know that this is wrong. And you don't want to go to your doctor because, you don't think it's going to get anywhere, and you won't let me do it. And he's like, yeah, dude, just, I'm going to tell you let me give you the approval code and let's just get on our way. And I was like, what the fuck? This is wrong. Bro, this is wrong. And and my staff heard this conversation, and they're like, they know what we're about here. We're about changing every fucking thing about medicine and making it great. And, we accept this nonsense. And I'm sure being in Canada, you probably accept this nonsense too. I know you guys have a stricter system than we do.
We have a really strict system, unfortunately, like we were talking about before the show. But yeah, go ahead. But
I've devoted my life to just finding this unacceptable. If we want our patients to take extreme ownership of their calories or whatever the fuck stupid shit we're going to tell them next, we have to take extreme ownership. And I don't see the extreme ownership in our profession. I don't see it. I mean, maybe you see it. I don't see it.
No, I don't see it. I think that one thing that we definitely need to improve on is, just being better role models for our patients, because the reality is that, people are not going to listen to you if you don't look like someone who takes care of themselves. And like, that's true with like everything. Like, you don't want to go to a mechanic whose car doesn't start. You don't want to go to, a barber whose like hair is all crazy and out of sorts. Like, you want to go to someone who looks like they know what they're doing. And I think that one thing we can do as a profession overall is to get ourselves healthy and to, be role models for our patients. But, it doesn't really seem to be like, that doesn't really seem to be gaining any momentum right now.
That's my medicine 1.0. Heal yourself. Medicine 2.0, take extreme ownership of your patients' lives, right? Take extreme ownership, okay, over their lives. If you're not effective, if they're not getting the goals that you want for them, if they're not losing weight, what are you doing wrong? Yeah. What have you not done? How have you failed, right? And to put it on the patient, the patient's got to take ownership. You can never do something for a patient. That is true. But your job as a doctor is the complete opposite. What can I do? What more can I do? How can I be better? How can we make the system better? And I just fucking pissed me off. This guy was like, I'm not going to give you my boss's name. I'm not going to go to my boss. Just take the fucking code. Fuck that doctor.
Yeah, no, that's absolutely ridiculous. And we need
the doctor's name is Dr. Sodi. Just Dr. Sodi, if you're out there listening to this, go fuck yourself. Okay?
That's a nice sign off for Dr. Sodi and a good way to end the show. But brother, where can people find you online? Where can they learn more about you, listen to your podcasts and everything else?
Yeah, everywhere, man. Everywhere. Dr. Tro spelled out, Dr. Tro spelled out. I'm everywhere. You could just find me anywhere. We have an app. You want to join that community I was talking about? We have an app. We have meetings every day. You could pop in every day to start learning about nutrition, start learning about medical topics. We have a curriculum. We have a course on cardiovascular disease you could take that goes over everything I just talked about. We have a free podcast. The app is free. Go get the fucking app. It's free. It is free. A lot of stuff on there is free. Okay. And we have a great medical practice. I don't take any more patients, but we have an amazing team, Dr. Laura Buchanan, and you can find me anywhere.
Awesome. Well, brother, it's been awesome talking today. I really, really enjoyed the conversation. I think you educated the audience a lot. So thank you so much for that. And everyone who's listening, thank you so much for listening. And as always, I'll be back again next week.